Thank you, George, for this very flattering introduction. I'm very honored to be here, very excited. But I do have a problem, which is that I really do not want to give this talk. And the reason why I don't want to give this talk is, that's my job, right? This is what I do all the time. I'm teaching a large group of undergraduate students or graduate students, and when I do that, I don't learn anything. And now I'm in front of a large number of people who are interested in the same thing that I am, which is, how do we facilitate change? And I don't want to be talking, I'm trying to hear myself. I want to more hear about what you're saying. So I'll try to just go over this very, very quickly so that we can actually spend the time that we should be doing, which is to hear what you guys are thinking about, how we can better understand the process of change. But I promised George that I would give a talk. And so I will be talking about, some of the problems that are related to our field. There are many, many controversies, many debates. As you know, people are actually debating about, is most of the change due by the technique that we are using? Is it an issue of relationship? Then, of course, there's a debate in terms of theoretical orientations, but it's very, very clear in my mind that the most important controversy, the most important debate, or it is the problem of a lack of collaborations between researchers and clinicians. In French, we would say, in my words, it's a maladroite indifférence, or a very, very costly Cold War, considering the complexity of the problem that we are dealing with. It's actually really, really sad that there is a lack of collaborations or a lack of a strong alliance between researchers and clinicians. In some ways, we could look at it as being, using the words of Kasdan, the manifestation of this difficult alliance is that researchers, because I think that people like I and George are mostly responsible for this problem when we're working in the world of academia. As Kasdan said, one of the things that researchers are doing is that we are letting the knowledge of clinicians dripping as water in a hole of colanders. And we're not paying any attention to this. And the other major problem is researcher like me who's doing a lot of research are presenting mostly to other researchers, and we're using a jargons, or we are talking in a way that is not directly clinically relevant or interesting. So one way of looking at it is we're putting our knowledge from research within a safety box, and we don't give the key to clinicians, like it's just for us, right? So I'm going to tell you about some, and it's remarkable convergence between what you presented this morning and some of the points that I want to make in my talk. I'm going to tell you about what I believe are some of the reasons that may explain the lack of convergence, the lack of collaborations, and then, as George mentioned, tell about some initiative that I think can actually optimize these collaborations. All right. So again, I think that faculty member or researcher or academicians are mostly responsible for this lack of collaborations. One of the reasons, of course, is that some of the research is not very, very relevant, especially with randomized clinical trials. Now, I do need to say, right, I'm a little bit defensive about this because I'm a cognitive behavior therapist. I have conducted randomized clinical trials. I will continue to conduct randomized clinical trials if funding agency finally fund me again. But there are a number of issues that are related to this, right, in terms of the relevance, right? So, I think that we are now finally making a lot of really, really good work together. But I just noticed this is our session 19. So next week is our last session. I know you're starting to change, but we're going to have to stop doing this. Right? This is one of the consequences of trying to apply research clinical trial to clinical practice. I have noticed actually that our last session, at least for me, and I think it was for you also, partially helpful. But then my supervisor watched the tape. And he told me that two of the interventions that I thought was really attuned to your needs I should not do that again. So whatever you got, you learned from this, please forget it. Right? So of course this is kind of, in a way, not going to facilitate the translations of the knowledge. And let's also be honest, when I actually conduct a study, it's based on what I find that is very, very interesting, right? It's based on my theoretical understanding or what I want to do. And of course, it's in line with what I think NIMH from the US or the Canadian agency thinks that they will be actually, they will find that interesting. So it's very, very clear that there's a lot of research that are not directly addressing the question on a day-to-day basis, hour to hour, that the clinicians are asking because they're coming from a theoretical and empirical program from researchers who are talking to other researchers who will actually be funding those researchers. So now this being said, and again, I don't want to be defensive because, I spend a lot of time in my office, so I actually want to have some of my research to be meaningful and relevant. I do believe that there is some research that actually can talk to clinicians. Just to give you a few examples. And it's come from my work. I tend to be narcissistic, so I'm just going to put it there. So this is just a few examples of some of the research could be done. So a colleague of mine, Larry Bertler, and I were actually kind of dismayed by the attitude of the field, where we would hear our graduate students or our colleagues to say, well, it's pretty simple. If you want to actually change, we just have to have clinicians to use techniques from empirically supported treatment. And then you would hear other colleagues say, oh no, this is so ridiculous. It's only and it's all about therapeutic relationship. And then other people would say, well, come on, that's not that. It's really about the clients. And then other people would say, oh no, it's not about technique, it's not about relationship, it's not about the client, it's all about the therapist. Well, we had this brilliant insight thinking like maybe all of these have something to inform, and they probably are in interaction. So what we did is we did a task force. We asked experts from different theoretical orientations. We had them to review what we know about client characteristics, what we knew about therapist variables in the therapeutic technique, what we knew about relationships. And we asked them to do that for 4 major disorders: depression, anxiety, substance abuse, personality disorder. And then what we had them to do is to derive clinical guidelines, principles of change that are directly related or anchor into those research and present it in a way so that it could inform the clinicians. So that's one example. Another example of clinically relevant research is, we're teaching psychopathology and most of the course in psychopathology, people are presenting really interesting and fascinating issue about symptoms, comorbidity, etiology, but nobody dares actually talking about what is the implication for psychotherapy. So with a colleague of mine, Tom Olsmans, what we did is we actually paired together. Now, people who, again, have never worked together, this time because they were psychotherapy scholars and psychopathology scholars. We asked them to review the field, right, in terms of what we know about the major disorders that are seen by clinicians, and we asked them to derive clinical implications that are, again, related to etiology or presentation of the symptoms. Right. All of this, by the way, those clinical guidelines are cut across different orientations because the finding is actually coming from basic research. It's not tied to specific orientations. Another example is for the number of years now with Clara Hill. Clara and I have organized a series of a conference at Penn State where we had scholars from different orientations who actually sits down in different methodological expertise and talk about, in a kind of an open, non-hostile discussions about major principles of change such as insight or corrective experience. So we meet every 2 years. We're 25 people around the table from different expertise. And the goal after this is actually to produce some chapters that have now been published in 2 books, one on insight and one on corrective experience. And what we actually, those conferences are not only kind of clarifying what those concepts are, they're arriving to a consensus about the nature of these phenomena, but they're also coming up with a series of questions in terms of future research, which I think are relevant for clinicians. So one of the questions is, does insight need to be true or historical accurate? Now, everybody knows, at least every cognitive behavior therapy knows, that Freud, the last text that he wrote in 1938, asked these questions. Is the insight that people are making as important as the therapist's construction of this insight? In other words, do we really actually need to get to the truth? And Freud actually said that in some circumstances, the constructions of the therapist is as important and as therapeutic as a true insight. But there's no research on this. Another question is, does more complex, emotionally intense, and central insight lead to stronger change? This came from a chapter of cognitive behavior therapists. It's amazing when you put people into a room and they are talking to each other, how creative they actually can become and how clinically relevant their findings are. Other few examples. There's some research that actually is pointing out that some of the variables that we think that is very unique to one orientations can actually explain the outcome of other orientations. So in a study that a colleague of mine, Adele Hayes, did for her dissertation, she was able to show that the extent to which cognitive behavior therapists talk about attachment issues in the early life of the individual with their parents not only predicted positive outcome, but actually explained the lack of relapse 2 years after the treatment. This is in cognitive therapy for depressions. In my dissertation, I showed that more the clients actually deepen their emotion in cognitive therapy, more there was change. So this is actually saying that research is pointing out the fact that our therapy may actually be valid, but they're not sufficient. We actually need to think outside of the box of this. And there's some research that my colleague and I actually have done that show that you can potentially improve some of our empirically supported treatment, at least from some clients, by looking at those 4 unique variables. So far, I just talked to you from a purely narcissist point of view in terms of my own research, but there's a lot more. There's a book that a series of colleagues, including Lynn Angus, who is there. Lynn is there. Yeah, we actually edited a book on trying to show that there's a major leader in the Society for Psychotherapy Research that come up with studies that are actually extremely clinically relevant and that we should actually pay attention to. And then, what research can also do is to address our main, or what should be our main problem, our first ethical duty, which is first, do not harm. And so with a series of colleagues, what we did is we actually look at what could be the training implications of research in terms of to decrease the negative effect that is actually taking place. I'm not going to go in detail about this, but basically we just came up with a series of guidelines about how to prevent or to repair toxic events that take place in therapy based on research, how to actually modify or adopt our treatment based on the client's needs, and at the same time also to identify that there are some of us who actually are creating more harm than others, especially working with particular clients. I can't see any clinicians who would actually say, you know, for me, harmful effect is not important. Or I can't see any clinician who would say, you know, I can actually spot them and I can actually solve them and I do not need knowledge to help me to deal with the fact that potentially I'm creating a negative effect. Right? So there is a way where the clinical research can actually be very relevant, but somehow, somewhere, this is not actually been presented in a way. And I think, again, it's the responsibility for the part of the researcher here. All right, so other difficulties for clients, for clinicians to actually benefit from research. Let's recognize it. Many of us have had some traumatic experience from graduate school. At my first class that I had at Stony Brook, this faculty member, extremely well-known person, who said there are 3 ways of accumulating knowledge or acquiring knowledge. One is by authority, so you read the Bible or Freud, it's about as same scientifically valid. The other is by phenomenology or subjectivity. And then he said, well, the only 3 way of acquiring knowledge, of course, is by observations. And with a very, very, very strong French-Canadian accent, I said, I believe this is epistemologically naive. Well, he took me outside the class and he said, look, Louis, at the end of the class, said, look, Louis, I think you're really smart. This is his words, not mine. But I'm really concerned about it. You see, there's 2 types of psychologists. There are psychologists who like ideas, psychologists who do not like ideas. And psychologists who like ideas go in academia, and psychologists who do not like ideas goes in clinical practice. And I'm worried where you're going to go, first days of grad school. right? So we all have these kind of trauma, whether it is in class or whether when we're defending our dissertation proposal. And even when now, we have the opportunity of conducting research, like I had, the chance that I had in graduate school, that were actually clinically relevant, right? I mean, these ideas of looking about the past in cognitive therapy, or to looking at a therapeutic relationship, or to looking at the emotional experience in cognitive therapy, came out from a lab where my advisor, Marv Goldfried, did not only change 5 times the field in terms of research, but he has been seeing 10 patients for the last 50 years, 10 patients a week. He knows as a cognitive behavior therapist that we do indeed talk about the past, that we do facilitate the deepening of emotions, and that the relationship is really important, despite the fact that these are not emphasized in the treatment manuals, right? But not all of us have this opportunity of working in graduate school with researchers that are not only doing really good research, but also seeing clients so that the research that they're doing actually can be clinically relevant. And so one way of actually dealing with this is to actually provide clinicians and researchers an ability to actually collaborate, as George was pointing out. All right, so how to get together to Rome? Well, fortunately, there is now a lot of research that is being done with the participations of the clinicians and the researchers. And we have very recently summarize this, but before I talk about this specifically, I want to say that in some ways, one of the ways to collaborate is to move away from what I call empirical imperialism. What I call empirical imperialism is the fact that you have people like me who are pretentious enough, presumptuous enough to actually, who sees 1 or 2 clients a week, to say to people like you who see 20 to 30 clients a week, say, well, if you really want to understand psychotherapy, this is what you got to study. And this is actually how you actually should be studying it, right? It's actually very presumptuous. This is not to say that there's not good stuff that can actually come out from the, Babel Tower of academia, but it's going to be limited in terms of the knowledge, and we need to have a kind of a more complementary perspective. And the complementarity perspective, I think it needs to be to develop some creative partnership, like what George is trying to do today, and to actually have a fostering of very active collaborations between the researchers and clinicians in all aspects of the studies. Now, as I mentioned, this has also taken place. With colleagues in mind, we actually define this type of research as being practice-oriented research. And we actually are making the argument that practice-oriented research is different and complementary to what we call evidence-based research. Most of the evidence-based research, whether it is empirically supported treatment or empirically supported therapeutic relationship, or all of the other studies or research that I talk about, are actually coming from the context of researchers, full-time researchers who are doing research hoping that it's clinically relevant. Practice-oriented research is very, very different. And there are 3 types of them. Patient-focused research, patient-based evidence, practice-based evidence, and what we're going to be talking about today, practice research network. And here are some of the characteristics, and you'll see it's very convergent to some of what George has been talking about. The first is that the studies has to be conducted. Now, this is a convergence between the 3 types of practice-oriented research. They have to be actually conducted within naturalistic setting, as opposed to be conducted in controlled environment. The second one is that it's based on actual use by all the participants in the research of standardized instruments that are actually part of the clinical routine. If we want to do some research that actually is immediately relevant, we actually have to do it with instruments that are actually being used, right? I think one of the problems with the research is that we're asking clinicians to use instruments that they will never be using again, right? Or that is completely different from their clinical practice. So practice-oriented research is actually doing research with an instrument that are actually based, so it does not add to the times of the clinicians. And the person can actually directly use those standardized instruments for the case formulations, implementations of treatment. And this research has a number of goals, one of which is to actually provide practitioners with an opportunity to participate into research. right? And this one, not just could you please fill out these questionnaires, but to be actively involved into it. Is to also, as George mentioned, is to have the clinicians to be able to use the data as it's being collected to inform their interventions during psychotherapy. To also examine questions that the clinicians will actually find to be very, very interesting. And the last one is to allow practitioners to actually contribute to the accumulations of rigorous science. Again, to go against the empirical imperialism, that the only people who actually will know what needs to be done and how we need to be doing is the people who see very, very few clients. Right? We need to actually change this. So, very briefly, I'll give you a few examples of, like people know a lot, I think, about the work of Michael Lambert. This is one example of patients-focused research. What Michael Lambert has shown is, very unfortunately, a substantial number of our clients actually are deteriorating from psychotherapy or during psychotherapy. In other words, they're worse than when they start working with us. His research is actually also showing that even though we think that we can predict deteriorations, we can't. We actually underestimate it, and we cannot identify the one who will deteriorate, right? But fortunately, the research is showing that if we provide clinicians feedback about the progress that the client is making, you can actually reduce deteriorations, and you can actually also reduce it further if you provide tools such as how to identify and to repair and to modify your alliance based on what the way that the treatment is going. This is very interesting, by the way, convergence between research and the clinical work. Way before any research was done on the alliance. And of course, all cognitive behavioral therapists know that. Sigmund Freud wrote a text in 1913 where he actually asked the question, when should therapists make an interpretation? And he said, we absolutely cannot make an interpretation until a good rapport is being developed. And he said, this is especially the case if your interpretation is accurate. And this is what he wrote. If the interpretation is accurate, usually the therapeutic effect at the moment is nothing. The resulting horror of analysis, however, is, well, I don't know how to say that in English, but it's horrible, right? So there's a convergence now that is taking place between what clinicians have been saying for a very, very long time and what the research is actually coming up, which I think, by the way, this convergence is absolutely crucial because it increases our confidence on the phenomenon that we're studying. If we actually are coming up with ideas and perspectives that are convergent, despite the fact that we're using different methods of knowledge, clinical observations, theory, and empirical finding, then we can be more confident that we got something here. Right? An example of research, of practice evidence research is, now most people know this, there is a very strong and recognized therapist effect based on the work of Boucher and Paul. We actually know that some of us tend to be more effective than others. And in fact now this research can be a little bit more specific. So, for example, there's a research that David Krause, some of my students and I did, where we actually were able to show that most of us actually are doing pretty good. We use an instrument at the top that is measuring 12 aspect of functioning of the clients in terms of symptoms or general quality of life. And what we find is that there are very, very, very few people in a huge old data set that actually are good at the 12 dimensions. And modesty is preventing me to tell you who the person is. No, it's not. I'm not the person. But there's only one person in the 3,600 therapists that we had who actually was good at all of the dimensions, right? Fortunately, there is very, very few people, only 4%, who are actually not good at any of the 12 dimensions. The majority is us, which is that we are good approximately between 5 and 6 aspects. So, but I would actually make the hypothesis that none of us, including myself, know what we're really good at. Right? So we need to have some data to actually tell us there are things that you actually may want to change, and there are things actually you're much better than you think you are. And we may use this information perhaps to supervise other people and to look what you're doing there that you may be generalizing to other characteristics. What's also very interesting, though, is that even though we know that there's a therapist effect, we don't know what it's caused by. We have no idea what are the therapists and what are the personal characters of the therapist that actually is explaining the therapist effect. And guess what? This is the next theme of the Penn State Conference, which the first one was about insight, the second one was about corrective experience, and now we have another one that I've started in the April 2012, which I think, again, is kind of pulling together people from different theoretical orientations and methodological experience to try to come up with some research and suggestion from research that I think will be interesting for clinicians. I cannot think about a research that would be more interesting than to say to the clinician, this is what we think you should be consider if you want to be a better therapist, right? The research there will actually be relevant. But the one that I want to talk more about today, the type of research or practice-oriented research that is very relevant to what we're going to be discussing is about practice research. Practice research network is really based on an active collaborations between the researchers and the clinicians. And when it is conducted in its optimal way, the clinicians are actually involved in every step of the way. Not only in terms of the implementing the studies, but also in creating and thinking in terms of what are the ideas that we find to be interesting, how to implement it, how to do the statistical analysis, and how to disseminate it, every aspect of it. So as George mentioned, in Pennsylvania, we have been doing this for a while. It actually came from the work of two visionary, Tom Borkovec, full-time academicians, and Steve Ragusea, the third author, was a full-time clinician who spent many, many years arguing that Borkovec was saying, well, if what you're saying is not valid, then if it's important, it needs to be valid from a research and perspective. And Ragusea would say, well, this is valid from a research perspective, therefore it's not important. And they argue for about 10 years, and finally they said, okay, you know what we're going to do? We're going to try to see if it's possible to have clinicians and researchers to be together to actually come up and to do some research. So in the 90s, what they did is they actually did a study where they put together a statewide infrastructure very similar to what we are doing, what you are doing here. And they tried to see if it's possible for clinicians to actually collect pre and post treatments using the same instruments as part of their clinical practice. And they were able to say, yes, it is possible. And they came up with very interesting findings, such as the amount of your caseload will actually be negatively related to your therapeutic effectiveness. More you're having client, less your clients in general will actually change. I think that's pretty relevant, right? And so from that study, then there was a second one. And the second one, what we did is we actually, in the phase 2 of the PPR, Pennsylvania Psychological Association, PRN, the goal is we wanted to, so what we did is we sat down, we were a number of us who were part of the first phase, and we said, all right, let's have a study, smaller number, in a small community in State College, and let's decide what are we going to actually study. And so it was a kind of an open discussions. And then I vividly remember there was one therapist who actually said, you know what I'm really interested in? I want to know after each of the session, what did the client find that was helpful? And if there's something that I did that the client did not find helpful or hindering or negative, I actually want to know this, right? So again, a very strong convergence between what the psychotherapy researchers were interested in the 90s and the early 2000s and what was come up with an interest of the clinicians. And what we were interested also to know is whether receiving knowledge after each sessions that we had with our clients could actually improve our effectiveness. Right? If you actually received the feedback, yes, you did that and I really like what you did, or you should do that again, can that actually modify or increase our effectiveness? So just very briefly, I'll tell you a little bit about the specific question. So, what were the events that were found by the client to be most helpful and hindering? What were the events that were found by the therapist to find to be most helpful or hindering? And what are some of the contents of the discussions when the event that was actually take place that both the therapists and the clients were saying this is important, what were they talking about, right? So you can see that of course, when you're asking clinicians, what do you want to do in terms of research, what you want to know, the research is going to be clinically relevant, right? This is not coming from the Babel Tower. This is actually coming from the interests of the clinicians. So of course, it can be clinically relevant. The question is, can it be scientifically rigorous, right? This is why the last project that I've submitted over the last 10 years at NIMH was constantly rejected, because NIMH do not believe that it is possible for having clinicians to participate in rigorous studies, right? The constant feedback that I receive, we do not believe you clinicians when they are saying that they will do these tasks. That's too complicated for them. I'm a little defensive about this. All right, so here's the method, the design that we had. Right? So within each of these three groups, child, adolescent, and adult, this is in private practice. These are people who are working in their private practice, right? So what we agree, right, is, and I was also a clinician, so what we agree is that for all the clients that would come for the next 18 months, right? So what we did, by the way, is like we met for 12 months on a regular basis, approximately once a month, to actually come up with the research design, the questions and the research design, and how we're going to be implementing it in our own private practice. Right? So we did that for 12 months. And then for 18 months, we agreed that all the clients that would come, we would actually randomize them into one or two conditions. In the experimental conditions, what we did is that both the clients and the therapists at the end of every session filled out the helpful aspect of therapy. It's a little questionnaire, I'll show it to you. And so we ended the sessions, and the clients and the therapists were filling out basically a very brief questionnaire, right? And in the control conditions, right, is only the therapist will fill it out. And this is because, even though clinicians are not rigorous in terms of their thinking for research methodology, is we figure out there's a potential confounding variables, which is like, well, maybe we're going to find this effective because it's not so much that we get some feedback from the client, it's because actually by filling out our card, maybe we're thinking more about what's going on, and maybe that actually is increasing the effectiveness. I thought that this idea of this control that came from clinicians was actually very sophisticated, contrary to what the NIMH is actually thinking. Right? It's going back to what the faculty member at Stony Brook the first day. Clinicians do not have ideas. They cannot think, right? So, and then what I'm going to do very briefly present about some of the results about the clients who were 12 years and older. Right. So, the participant, we were 13 experienced therapists in private practice, all but one full-time clinicians. I was the one in there. We had 121 clients. Now, this is only for the two of the three groups. We had a total of 151 clients. Think about this. 150 clients from clinical practice paid full fees, right? This is very important to kind of know because it actually is able to show that you can maintain your full practice, right? And you will not use your client. You can actually put it within your practice and still charging full. This is so different from the type of research and control setting where you actually pay the clients to be participating in the research, which of course will make the research in terms of generality, in terms of external validity weak. Here it's really talking about the clients that you will actually see in your natural practice. You'll see that the design that we had was to decrease as much as possible any obstacle that, or make it as syntonic as possible to the clinical practice. We had a mean of approximately 9 clients per therapist, and the mean sessions for our clients was around 7. All right, so here's the instrument, right? So the question is was there anything that was partially important or helpful that took place today? If yes, quoted from, very slightly helpful to extremely helpful. And then what we had is we actually had them to briefly describe that. Then we had that on a little index card. And then we turned the index card, right, and said, was there something that actually happened today that was partially hindering or negative? And then you had to rate it, and then we say, please describe this, what actually is taking place. Okay, so here's the procedure. Again, based on the characteristic that I told you earlier in terms of the fact of, we wanted to use a standardized measure that was part of the clinical routine. So what we actually did, and that was, by the way, one way of actually addressing the concern of one of the enemy of research from my perspective, which is the RRB. Right? They're there to prevent research, from my perspective. So we actually said, because you should see what the way that the RRB, at least in the States, is reacting about doing research in clinical practice. I mean, they have absolutely zero ideas, right? I had an argument with one person in the RRB. What they wanted to do, they said, you can't have your clinicians to consent your client, because the clinicians will be, may actually twist the arm of the clinician, of the clients. I said, no, you don't understand. If the clinician is going to have to choose between making money or collecting data, they'll go with the money. They will not. So what they wanted to do is, once the clinicians identified the potential clients, we'll send an undergraduate to actually ask them the question, what about the confidentiality? Right? So therapists will start the session by saying, well, now that you're potentially interested, let me give your name and your phone number and email to an undergraduate at Penn State who will actually come and visit you. So one of the ways that we solve this is we actually, now when the clients were coming in, right, for the next 18 months, all our clients were using the top as a standardized clinical practice. So we actually said that to the RRB, and they could not say anything bad about it, because this was part of our clinical routine. So we actually have been using this. And then, after every session, the helpful cards were actually filled out, and by the clients and by the therapists. And the only thing that we actually agreed to do is that before the next sessions, we would read the card for the clients. We did not agree, or we did not discuss how we're going to handle this feedback. We just said, why don't you just kind of read, or why don't we just read the cards, and based on what we hear from what the clients find helpful or hindering, we're going to say, how could I potentially use this information to be more attuned to what my client is actually needs? Right? That's it. Okay? And then at the end, we ask the clients to fill out the top. Now, here's a major problem that we encounter. We had only 30% of the clients who actually filled the top at the end of the treatment, which means that the second question we wanted to know, which is can we increase our effectiveness by actually receiving feedback, by comparing the control conditions with the experimental conditions? We were not able to answer it, right? Which was a major, major lesson for us in terms of time and energy that we spent in not being able to answer these questions. Which, of course, now in another study we have tried to address this problem. So briefly, what are some of the results? Well, when we look at what we did after we actually collected those helpful events, we actually trained for 8 months 4 graduate students who actually then coded those events based on a coding system that Robert Elliott came up with. That look at events from a different theoretical perspective. And I should say that all the clinicians were in naturalistic setting. Nobody was purely psychodynamic or purely CBT or purely humanistic. There was a blend of an integrative position, but was representing most of the major orientations. So there were therapists who were primarily CBT, some primarily psychodynamic, right? And when we look at what were some of the events from the part of the clients that they find most helpful, the client were saying, well, what I find the most helpful are events where actually I increase a sense of awareness. So to kind of giving you an example of, on one card, One client said, it helped me to talk about what fears and thoughts are, that my fears and thoughts are normal and how I'm starting to be better. And an example of awareness from the therapist is exploring painful events and allowing her to experience and express feeling of sadness and shame. So these were, the type of events that were judged by the therapist and the clients to be the most helpful. So there was a convergence there. Interestingly, there was also a convergence in terms of the content. So what was the thing that people were talking, that the clients and the clinicians were actually talking about during those sessions where they find that there was a very high level event? And both on the positive and the negative or hindering was talking about the therapeutic relationship. So these are some examples of this. This is a positive event talking about the relationship from a client. I find helpful to share the responsibility of change. I find helpful his honesty and relatedness. The therapist, we seem to form a very close bond almost immediately. An example of the therapist saying that of an hindering effect, talking about the relationship, my frustrations might be showing. And one example of the client is, I feel like I'm under attack, at which point I tend to withdraw. So these were, of course, toxic events that were pointed out by both the therapist and the client. So there was a convergence here between what the therapists and what the clients were actually seeing as being positive or negative. By the way, the fact that there's convergence and statistically doesn't mean that we're not points of dissimilarity. I vividly remember there was one sessions with the clients where I had the insight of the century. And that's what I wrote on my card. This is the insight, the interpretation of the century. Essentially what it was, right, is I brought this up, right? I told you I'm narcissistic. So I brought this up, right? See, she was actually talking about an event that took place, and I linked something that took place with her father, took place with her husband, and was in the room. We do that in CBT all the time. So I was just wrapped this up really so nicely, right? So yeah, that was really, so I was writing it up, right? And I saw that she was writing her card, right? And I was dying to see what she was saying. So she gave me the card, and then, she goes and write the check, and then she goes, and then I was kind of like, oh, I'm going to look what she wrote. And then I saw, yes, there was an helpful event, yes. And then, yes, grateful, yes. And then I read and said, you will never abandon me. Who? I do have to say, but at the next session, I started, was there anything that I said last week that was, I really thought this was really good. Was there anything that I said? No. Okay. But there was nothing like in particular, no, it was just like, you allow me to talk about these things where I don't feel any shame. Okay. So it's kind of interesting, that we agree there was something that was taking place here, but that my perceptions and the perceptions of the clients were very different. And guess what? What is the most important? Of course, it's the perceptions of what the client is, right? So these are some of the examples. And then what we did, when we were done with this research, again, we collected the data for 18 months, and then we coded them. We actually had some interviews, and we actually interviewed the therapists and basically asked them questions like, well, what did you find beneficial as conducting this research within your practice, right? Is there something that you find that was actually negative, and what were they? And then is there obstacles that you actually were facing? And when they were, how did you solve this, right? And then we also asked them, well, what kind of recommendations that you have, right? So this is the article that you have in your package there. So very briefly, I was just going to tell you a few of those, right? So, one of the things that therapists is saying, this would be, I think, relevant to your experience, was saying, we really like, the fact that I learned a lot, both clinically and empirically. And therapists were also saying, I think, even though we did not have any outcome measure because we did not have enough people who fill out the top, people were saying, I am absolutely convinced that my clients benefited therapeutically by this because I actually changed my interventions based on the feedback that I received from the client. That I stopped doing the event that they perceive as harmful, or I explained more why I was doing it, and I did more of what they find helpful. And it showed. It provided me with an ability to establish a new relationship. I find that it was very gratifying to develop and implement it in a scientifically rigorous way, studies that were experienced as stimulating and gratifying process. Contrary to what NIMH is saying, the research participation was intrinsically meaningful and rewarding both from the clients and from the therapists. There were some clients who were saying, oh, so I'm going to participate in a study that's going to help Penn State? And they were actually thought that this was actually very meaningful to them. There were some obstacles that people were facing. You know, if at the end of every session you have to fill out L4 cards, right, for all of your clients, while the therapists were actually saying, sometime I got to choose between filling out the card or going to the bathroom, right? So this pragmatic event. You also have to learn new ways of doing. Clinical practice is very complex. There's a lot of things to address. So adding a new sets of procedure, even though these are sets of procedure that I, as a therapist participating, I define, and I spent 12 months defining it, right? I find that was difficult. Now, there's a number of recommendations. Again, I'm going to go here rapidly because it's in the article and it is, you have my slides. So the first one, right, is research should be clinically relevant and the scope of the study should be manageable. Now, of course, the first one, right, seems to be, very, very, very obvious, right? But actually, more specifically, right, if we want to do research to actually, that will be clinically relevant and scientifically rigorous, right? And let me be narcissistic again here. I think that I figured out how we can actually solve this problem. We can solve the problem of a lack of this gap between research and practice. If we are actually engaged in research and in research tasks, right, where it is impossible to actually decide or to figure out if what we're doing is research or if it's clinical work. So when, as a clinician, I would read that card, right, especially the one which is, "You'll never abandon me," right? And I was reading that. If you had asked me at that right moment, am I doing research or am I doing clinical work? I would have said, I don't know, right? And the reason is because obviously I was doing both. That's the best way. If we can actually doing a research that intrinsically at the moment is informing us, and especially if it's based on questions that we find to be relevant, and especially if it's actually allowing us to address problems or good things that happen right here, right now, right? There's not going to be any more gaps. There's not even going to be any more bridge. By the way, we have to stop thinking about this metaphor of creating a bridge. Because creating a bridge, right, is kind of assuming that we are on different banks, right, of a river, right? And once in a while we have a connection.